Welcome everybody to the weekly meeting of the coalition, the Tacoma-Pierce County Coalition to End Homelessness. I was thinking about the name of our group this morning, and the most important word in there is end. It's a verb that takes a whole lot of effort to do. And when this coalition was started many years ago, Maureen will remember being a leader in that effort, that to end homelessness seemed important and doable, and it still seems important and doable. But the verb end makes us really have to think about the constancy that we've given to the task and our commitment to continuing to make that actually come true. So I'm wanting to welcome everyone here. We have some new folks with us who are maybe going to share things with us today. And so we use this time just briefly to welcome you and to ask you, if you would, to identify yourself. If you're associated with the group, just to mention it. It's not a long introduction, but just so you can know who, we can know who you are. And also in our chat function on here, we encourage people to put contact information if you're willing to or want to have more contact with us, so that folks who interact with you possibly on screen will know how to get in touch. So with that, I welcome anyone who's new today or returning after a long time away to let us know you're here. Just unmute yourself and say hello.
Hello, I'm Jenna Anderson. I'm a resident on North 30th Street. I've connected with a few meetings now. I call myself a compassionate resident who really wants to get involved. It's a burden on my heart. So just getting involved with the coalition has really, I have felt a connection and an avenue to push my concern into so I can help. So I'm a finance manager with CareNet Pregnancy and Family Services down the street by Allenmore Hospital. And I work part-time, so I have some days that I can definitely lend to these meetings. Thank you.
Welcome, Jenna. Thank you very much for coming. Good to see you.
Good morning, everybody. It's Robin O'Grady from Fusion and Federal Way, and I'm just trying to get reconnected. I was here probably a month ago and just want to pop in and see what's going on.
Well, welcome, Robin. Glad you're here.
Thanks.
Good morning. My name is Kat Green and I'm with Associated Ministries. I'm a rapid rehousing specialist and case manager. And this is not the first time I've been in this meeting, but I know many of you have not seen me. So I wanted to say good morning.
Well, good morning, Catherine, and welcome.
Thank you.
I'm Craig Jacobson. I work with the Healthcare Authority. I'm the program administrator for our Forensic HARPS program. We have two of them in Pierce County with Greater Lakes Mental Health and then Comprehensive Life Resources. So
that's wonderful to have you join us, Craig. Thanks.
Thank you for having me.
I'm John Van Buskirk, a family physician at Tacoma Family Medicine Residency and involved in the neighborhood clinic there at Hilltop, and just more and more impressed about how homelessness and home insecurity issues impact on health, and really looking for what we as healthcare providers or members of the community or healthcare organizations can do to work on this task. So I'm just impressed at how much activity already is going on. So looking forward to learning more today. Thanks.
Welcome, John. It's good to see you.
Good morning. My name is Pamela Williams. I am a housing specialist / care coordinator for MDC. I work with the HARPS program, which is representative of Trueblood Foundation, or the Trueblood element.
Wonderful. Thank you for joining us, Pamela. It'll be important to hear your voice too. Thank you.
Hey, I'm Arrow, and I'm with Food Not Bombs, and I'm also the founder of the Food Not Bombs Street Medical Collective, where we do comprehensive first aid and medical services, as well as mental health sort of practice all around town at the different houseless camps.
Excellent. Thank you, Arrow. It's really important work.
Good morning, all. My name is T.I. Deladen. Most people call me True. I'm a peer specialist, certified peer specialist with the Trueblood initiative element program with MDC.
Well, welcome, Truth. I'm hoping you will speak it as however it is. Thank you for being here.
I will share. I'm Kimberly Bjorn. I'm with Elevate Health. I'm going to be talking about Trueblood today, and I just wanted to do a special thank you to Pamela and True for being here.
Excellent. Thanks, Kimberly.
And anybody else that might not have said anything yet that's part of the forensic team, and Craig especially for being here.
All right.
Hello, how you doing? I'm Nathan. I am the program manager of Forensic HARPS at MDC.
Wonderful. Thank you, Nathan, for joining us.
Would you briefly say what MDC is? Thank you.
I don't know that Nathan heard you.
Metropolitan.
Go ahead, True. Go ahead, True. You got it.
Metropolitan Development Council.
You'll find out more, I'm sure, Jenna, as we go along here today. Thank you again for joining us, Nathan. Anyone else? One last chance for letting us know you're here. If not, just put your name in the chat or let us know if you want to be contacted at some point. We'll try to do that. Rob, I think I'll get back to you. Oh, we have somebody else with their hand up.
Good morning. I'm Adrian. I'm an engineer. I work for AI Housing Systems.
Hi.
And just
Hi, Adrian. Good to see you. I'm sorry I missed you
nice
earlier.
to meet you.
Great.
Just sitting in, see if we can
Thanks for joining us.
good systems.
All right.
Well, thank you, Rosemary. I think we will, I want to welcome everybody here this morning as well. And so we have a very full house, so it's great to see everybody, virtually at least. Quickly, why don't we shift to our regular session on this week on the streets. I don't see Nathan on the call with us this morning, but this is the opportunity for those who are working directly with doing outreach and in, for instance, the warming centers to talk about what they're seeing on the streets this week. So I'll open the floor.
I see
Irene, I see your hand up. Yeah.
Okay.
So one of our comrades in Food Not Bombs is the food manager for the East Side Warming Shelter, which is now closing. So he's there right now helping to close it. Tacoma Housing Now did a protest on Wednesday that drew quite a few people and did some organizing around trying to take next steps in terms of how we're going to get folks services. There seems to be a very clear incongruence between what the Metro Parks is saying around the folks at the warming center and what our person, Austin, who works there, is saying. So the city right now in Metro Parks is saying that the majority of people, if not every single person, has been connected with services. And Austin is saying at least 3/4 are going to be back on the streets by next week. So there seems to be a real incongruence between those two things. We're also dealing medically with a lot of COVID that is sweeping the camps right now. So last week I brought someone into the hospital for a very severe infection. He tested positive for COVID. He was living in a trailer down at the pilot camp with a bunch of other people in his trailer. And then when I asked him, he said, you know, like half the camp is in and out of that trailer and none of them are wearing masks. A lot of them had also come over from the casino camp that got closed down. And 2 days before the casino camp got closed down, I took someone to the hospital for a severe infection and they tested positive for COVID. So there seems to be a pretty severe COVID outbreak that's sweeping through the pilot camp and all camps that like sort of associated with those two camps, as well as some pretty severe infections. So from the medical side and warming shelter, that's kind of what's going on.
And I just want to briefly say, just increasingly dismayed that, you know, we say, give us hygiene stations, give us sanitation, porta potties, and it's been months now and it falls on deaf ears. And I know a lot of you have been saying the same thing, and it's just dismaying. And I'm so tired, and I just, at this point, I'm about ready to give up. People are dying and there's just, nobody cares.
Well, we definitely hear you. I see Robin O'Grady with her hand up, and then Jeffrey.
Can I just get clarification, you guys? Is the North Point and the Tacoma Eastside Community Center, are those two separate programs?
Well, they're both run by Vallejo, and the fact remains that closing down beds is closing down beds. The new shelters like Bethlehem that are opening today, they're for families only. Like it's not comparable low barrier beds.
And then can you confirm the date that those will be closed?
Yeah, can I answer some of these questions?
Yeah, Mike, you definitely can.
Well, especially I am here, okay? And some of the information that's going out is dated information. Okay, number one, we basically have 3 or 7 people that have made the choice that they don't want any services. Okay, to say a large number of people are going to be pushed out, okay, and having nowhere to go is inaccurate. Okay, we've done almost 90% of the people that we have got them in different locations. We are working right now with Bethlehem to put 13 people in there. Bethlehem is taking couples as well as single women. Okay, the shelter is right now today. We're asking people to leave by 10, 11 o'clock, noon, in that time frame, and we're trying to get them transported to wherever they want to go. Okay, and then it's going to take us a while to clean this place up. So technically, the contract expires, if you will, on February 28th. Okay, so I have until February 28th to get this facility, as well as North Point, back to where it was when we went into the facility. Okay, and I would really appreciate it until the 28th. If someone needs numbers or what's going on at North Point or East Side, okay, call me. Because I'm going to try to squelch every one of these negative points that some people are making. Sorry, little bending there.
Thanks, Mike. Can you drop your contact information in the chat so that folks can reach out to you if they want to?
Yep, doing it now.
Perfect. Thank you. Jeffrey.
I talked to the CLO for this Lincoln neighborhood, Steve Bucks, yesterday morning. The encampment on 38th and G has approximately 20 people right now, and that camp is going away. They have been informed to either accept some form of sheltering or move. And they got the word yesterday. I have talked to them, they're concerned. I have no idea where these 20 people are going. Oh, and the date I heard was sometime early next week.
Thanks for that update, Jeffrey. They didn't say where they were being offered shelter?
No, and neither did the CLO.
Okay. Others with updated information about what's going on in the streets this week? Okay. Thank you for those updates, difficult as they are to hear, and do know that everybody is here to work with and serve the folks who are out on the streets. So don't lose hope. So our next item on the agenda is I have Tegan from the city. And Tegan, I'll let you take the floor to queue up the breakout groups that we're going to do regarding informing the city's plan, homelessness plan.
Thanks, Rob. It's good to see everyone this morning. I missed a little bit of the check-in. I was having some technical difficulties, so I'm sorry to have missed some of that because it sounds like there was some good conversation happening of support that's needed on the streets. So today we're going to talk about, hopefully in the breakout groups, racial disparities and inclusion. And so what I want to tee up about this is every breakout session from here on out, we're really going to talk about racial equity and how it impacts individuals at each stage of the homeless continuum. And so what I want to share is that we're really pulling some of our work from the SPARK report. And if anybody doesn't know what the SPARK report was, it's supporting partnerships for anti-racist communities. It was done, started in 2016. 2020 was the end of their second phase. So some of the key domains that they said were influencing homelessness and the impact of persons of color were primarily economic mobility, unavailability of affordable housing, involvement with the criminal justice system, a variety of mental health, behavioral health issues, and family stabilization. So that being said, what we really want to talk about today, before we jump into the continuation, we're always going to have a question around racial equity and how to support people of color at that stage of the homeless continuum. So what we really want to talk about today is like, how are we already collecting client invoice and feedback from individuals in particular systems? So what we're hoping to ask is, think about how your agency or the work that you're doing collects client feedback, especially of people of color, or do you not? Because I think that's also an important component if we don't collect that feedback. So the questions today, and I will put them in the chat. The first one we're going to ask is, within your existing programs or your area of work and expertise, what avenues do you use to hear direct feedback from Black, Indigenous, and people of color to individualize the utility of their services? And how does your agency act on that feedback or support the BIPOC community? So big ones. And if you don't, because I mean, we can also sometimes get informal feedback as well, and how do you use that? So we're really getting at like, how do we hear those voices? How do we incorporate them into our work? So do we have any questions before we start? And like I said, I'll put these in the chat as well.
Welcome back, everybody. So the drill, now that we're back in the main room, is to pull together your notes from the breakout and paste them into the chat so we can get those to Tegan and help inform her process with the city. So we will shift to the next item on the agenda. Tegan, did you have anything else that you needed to add before we move on?
I don't. I do want to apologize to my group that I hit my button to return when I was just starting to talk. But no, I appreciate everybody's feedback as always. You guys are great. So thank you so much. And I know I'll probably have an update at the city update later too. So I'll be gone.
Thank you. Awesome. So we do have a packed agenda today. So I want to move on to our next topic and invite Kathy Ryan to begin the conversation about how hospitals discharge people to shelter. So Kathy, you have the floor.
Hey, good morning, everybody. I'm Kathy Ryan. I'm the Emergency Department Social Work Supervisor for Virginia Mason Franciscan Health. We just got rebranded yesterday, and we're happy to join Virginia Mason in a partnership. I am doing a presentation with Kim Cummins, who is from Multicare, and then my co-supervisor, Kirk Tracy, who can introduce himself shortly. I just want to say right out of the gate, one, I have the sunshine issue happening at my house right now, and then I'm having some bandwidth issues. Kim has a PowerPoint, because the three of us are going to do a little quick overview of the hospital system and how we engage with our homeless population, and then the barriers and limitations of what hospitals can and can't do. And I'm not seeing her on there, so I'm wondering if Kim can, I don't know if she's on a different screen.
I'm here. I need to share the PowerPoint myself, or is someone, I can do it. I have it up if needed.
Kim, I can make you a host so that you can share it. So just give me a moment and I can do that, and then you guys can get started.
Great. Okay.
All right. Let's see.
So while Rob's doing that, my name is Kim Cummins, and I'm the Executive Director of Hospital Case Management for Multicare Health System across the Puget Sound and Inland Northwest. I'm excited to be here and partner with my colleagues from Virginia Mason CHI.
And you should have the ability to share now.
I'm giving it a shot.
It's working.
Hey, okay. So thank you all so much for having us. My name is Kim Cummins, and you met Kathy. Kirk, would you like to introduce yourself real quick?
Sure, thank you, Kim. First, can you all hear me? Okay, great. My name is Kirk Tracy, and I am the acute care social work supervisor for both St. Joseph's Medical Center and St. Clair Hospital. Hopefully the mask is not muffling me too badly, but I am in a shared work area, so I do need to keep this on.
Well, what we hope to accomplish today is really to begin the journey of, and continue what I know all of you have been working on, but to begin a journey of improving transitions of care from hospitals to the community for persons who are experiencing homelessness. We also want to help all of our community partners understand hospital operations and hospital needs so that we are providing exceptional medical care to people when they are sick. And then we want to be a part of brainstorming shared solutions for the disposition process from the hospital, as well as emergency rooms. And of course, knowing that that will be continued conversations, that we're not going to solve everything today. But thank you for this opportunity. So Kathy's going to go first and talk to you about the emergency room process.
So just, I don't really like to read PowerPoints word for word, but I'll just hit the highlights of it. So we just wanted to kind of give an explanation of how individuals in the community, including those that are homeless individuals, access services. So our emergency departments across the system, in particular in the Tacoma area, which is Tacoma General and St. Joseph's Medical Center, we provide medical treatment for 100 to 200 patients in a 24-hour period at each of our hospital systems. We generally only have one emergency department social worker on at a time. And then the difficulty happens if a social worker calls out sick or there's a gap in services. Some of the ERs in our hospital system, which ranges across 3 counties, but in the Pierce County region, they don't always have a social worker on. They only staff according to their busiest days and evenings, and not every single day. There is limited social work availability on off hours, but that's not always consistent if staffing is an issue. For the social workers in the emergency department, true or not true, but psychiatric emergencies oftentimes will take the majority of the social workers' time for all kinds of reasons unique to Washington State. So typically when an individual accesses our emergency department, and it's regardless who the individual is, I know that we're focusing on the homeless population for this reason, but I just wanted to point out that we treat all of our patients, we provide the same care and treat all of our patients as our patient. So they typically access through one of two ways, either through our lobby or via the ambulance bay. And they're seen by a triage nurse, then they're assigned a bed nurse, and then they're assigned an attending physician. We are consultative services in the social work realm. So we rely on the provider, the attending doctor or physician to refer to us. And we do not see every single patient that comes into the ER. So all of our referrals, at least in, and I think this is the same for multicare, but in our Franciscan health arena, they come from the provider. It is up to the doctor to determine if the patient needs to see a social worker or not. So I think that there may be a misunderstanding in the community that social worker will engage with every single homeless individual, and that is not always the case. It is up to the provider. We oftentimes will advocate to see the patient. However, the consults are driven by the doctors. And then they put an order in, and these orders can range from mental health assessments, suicide assessments, referring to the DCRs for involuntary commitment, making referrals to outside providers. We'll assess for the appropriate resources upon discharge. And so basically what we're doing is assessing for the level of care that that individual needs. And then we're trying to access resources in the community. And because we're 24/7, our resources are not always available, especially on weekends at 3 a.m. on a Sunday morning, as an example.
And just to add to that, Kathy, we want to touch everybody that we can and provide those services. But you can imagine in a busy emergency room that sees, 150 patients in a 24-hour period with only one social worker, there are many, many days, many shifts when we may have 6 or 7 patients in an active psychiatric crisis who have tried to harm themselves or who may be responding to voices. And we're really trying to help stabilize that patient, find out what their history is, what services have worked for them in the past, what medications have worked for them in the past, and one social worker supporting the care teams for 4, 5, even 6 patients with significant behavioral health immediate needs would be their focus. And that may be one of the reasons why a physician may not write an order to a social worker at a time when someone who may be experiencing homelessness may arrive to the ED with a lower acuity medical need. And so just kind of wanted to help people understand that picture.
Just really quick, I just wanted to, I noticed that there's some chat questions, and I'm not going to be able to talk and multitask, unfortunately. I don't have that skill set. So I'm hoping that when we're done, if somebody can keep an eye on those chat questions, I know the 3 of us would be happy to answer them.
Yeah, we will.
Awesome. So I'm trying, I think this next slide is, again, one that I'm going to go over. These are ER, emergency room, barriers and drivers for disposition. Just so that you know, in our world, we call it the emergency department. So if we slip up and say ED, it's the same thing as the emergency room. Just in our hospital systems, we just call it the emergency department and not just an emergency room, because there's lots of other things that happen in the emergency department. So some of the things that happen in us determining a disposition, and just I just want to give kudos to Kim Cummins. She put the slides together, which is very helpful for Kirk and I. So I do appreciate her doing that. So when a patient comes in, one of the things that we have to consider, and there's laws around that in the state of Washington, is patient rights and patient choice. We cannot force anyone unless we've determined there's imminent risk of danger to the community or themselves, or they meet grave disability criteria, which is all legal. we can't force somebody to take any kind of resources that we offer. And we can't force someone to go to a group home, a skilled nursing facility, shelter, or medical respite program. We really have to follow the guidelines. So what we really basically do is we're determining level of care, exploring all least restrictive alternatives, and trying to match the appropriate resource that's available with the patient. But they do have choice and they have patient rights. A lot of times the emergency room and community workflows don't sync up, which means we're not just open business hours to be able to access outside resources. Every resource in the community typically has different hours of operation. And because we're 24/7, it's very difficult to find those resources after hours. There are many times, I should backtrack, there are not many times, but there are a fair number of times for whatever reason that a patient will elope, especially if we're trying to offer them options that they don't want to receive, but that's all the options that we have available to them. We're really big on what's called emergency room throughput because we have limited number of beds in our hospital system. At any given time, we can have 40 to 50 people in our hospital system that are ready to be discharged, but there's absolutely no place for us to send them. And so if you have a true emergency that's coming through, we really need to look at turning our emergency rooms over as quickly as possible. Our goal is to turn those beds over within 90 minutes. However, I just checked the ER track board at St. Joe's shortly before I got on this call. There are 2 patients sitting in our emergency room with over 20 hours each. Both of them are ready for discharge. Both of them have been assessed for level of needs, but the receiving facilities either don't have beds or are waiting for someone to accept them. So that's the reality. So we have a limited number of beds. We have an enormous number of people coming into our emergency department seeking whatever services that they need. And then sometimes we just can't move them out as quickly as we like. One of the things I do want to point out that we would love to have in this community is after hours access to shelters. And what that means is my social worker would be able to call someone at 2 a.m. and say that we have this individual that's ready to get discharged. They're ready to walk out the door. They don't want to be in the hospital. They don't want to sit anymore waiting until daylight. Can we send this person right now? We oftentimes do not have that ability. So it'd be great if something like that could be developed, especially for those with behavioral health issues. They have some crisis, they're not at imminent risk. However, the hospital system is not the most appropriate avenue for them to get services, but we just don't have any other options. Sometimes the provider will choose to discharge the patient, and we just don't have any control over that in the social work arena. The cost of care of sitting in an ER room is about $700 an hour at minimum. It's very costly. I know that money could probably be used to develop a shelter bed. I'm not a politician or a person that can make that happen, but we just wanted to point out that it's very costly for individuals that have no medical reason to be in our hospital system, that it does cost money that comes from somewhere. And I think I've covered all of that on this slide.
And I would add too that, the mission of the emergency department or the emergency room is really to stabilize that emergent need, that emergent medical need or psychiatric need, and then determine where does the person need to go? Can we stabilize and discharge home or to a setting that's more appropriate so they can get the continued care, or do they need to be admitted to the hospital? Imagine sitting on a gurney. It's not a hospital room or a bedroom in the emergency room. It's not a hospital room where there's a television. It's not a room where there's a private bathroom. It is not where you want to be for 20 straight hours and the lights are on 24/7 and people are coming through and in with other emergencies. It's noise. It's not meant to be a long-term healing environment. It's really meant to take care of that immediate emergent need, that trauma, that car accident, that stroke. that internal bleeding, whatever's happening. And so that setting is very meant to be a short-term kind of a setting. And for those folks, for example, who might spend 20 hours in the emergency department, some of our emergency departments even are not attached to a hospital that has a kitchen. And so then we're having to think differently in a way we never think before. An off-campus emergency department, a satellite emergency department, someone has to think, oh my gosh, I need to run out and get a sandwich for this person, because the normal time in an emergency department really is about 90 minutes. That's what the goal is. So just want people to think consciously about that, that really the emergency department's not meant to be a temporary custodial placement, if you will. And so I wanted to kind of give that sense. So Kirk, you want to talk a little bit about inpatient?
Sure. Thank you, Kim. So I'm pretty much just going to work off of these bullet points, I think, for the most part. And so here, this slide, we are going to talk about the inpatient process and procedures that guide the patient stay here in the hospital, as well as the work that the social workers do with the patients. The inpatients do require, I can't, I'm going to try to exit the full screen because there we go. Sorry, the pictures were cutting this off. Inpatients do require referral to the social worker from a physician or case manager. And by require, there, with the current workloads that we have and staffing and whatnot, without an order, there is a chance, of course, that a social worker may not go. We don't have the capability of speaking with every patient that is in the hospital, is what I'm trying to say here, and doing a bad job of it. We do rely on orders from physicians and other disciplines as well to hopefully put patients on our radar. And simply, I do want to clarify that just because there is not an order in that a physician orders, does not mean that we will not work with that patient. I guess what we're trying to say is that it can contribute at times. We may miss a patient because they were not put on the radar of the social workers, that there is a need that needs to be addressed. The social workers will complete an assessment of the patients based on their patient need. And of course, as Kathy had mentioned earlier in one of the slides, we do include patient choice in that, of course, and that is always our starting point with any patient is, where would you, or, what do you want to see happen during this hospitalization? When you are ready to leave the hospital, what is your preference? We do have a program with a local shelter where we can offer them the option of a bed at a shelter. We are very limited in that, but I'm bringing this up because, once again, the importance of patient choice. We will oftentimes have people tell us that they would prefer to go back to their previous living situation, even if it is on the streets, in a tent, in the woods, what have you. We will get turned down on the offer of discharging them from the hospital to a guaranteed bed in the shelter. The average length of stay in our hospitals, it ranges from 2 days to 5 days. And we do our best to promote early discharges to align with the ED demand, i.e. once our patients in the ED that do need to be admitted, we, of course, our goal on the acute side is to make sure that we are getting patients discharged in a timely manner so patients do not have to inappropriately sit down in the emergency department for an extended period of time. One of the things that really makes, or as far as I know, my entire healthcare career has been in Washington State, but it is my understanding that we do operate a little bit differently in terms of the requirement of submitting a certificate of need for hospital beds to the Department of Health. A lot of states, if you have the money, the land, and the desire, then you just go ahead and put up a hospital if you so choose to. And that is not how Washington works. And the end result of that, of course, is that on a daily basis, there is a shortage of hospital beds in Western Washington. We are currently at surge capacity already at St. Joe's right now, as we were yesterday and the day before. And St. Clair is near full capacity as well. And this is a common occurrence throughout all of Western Washington. And the minimal daily cost of an acute care bed is approximately $1,000 a day. And so, once again, it's a resource that we have to do our best to protect and make sure that the beds are available on a daily basis to treat the acutely ill patients within the community. And it is truly a struggle already on a daily basis related to the lack of available beds, as I mentioned earlier. Kim, did you have anything you wanted to add?
I will add, I think I'll tie back to the comments earlier about the 2 individuals who were brought to the hospital who were COVID positive. So to help people understand how the hospital sort of, where patients go depending on how sick they are, we have intensive care units, ICUs, and a very, very sick patient who needs to be ventilated with that kind of an infection with a breathing difficulty typically would be in the ICU. Once someone improves and they downgrade, but they still need to be in the hospital, they would downgrade to a progressive care, a PCU bed, or a medical bed. And what ends up happening when we have throughput issues or a lack of community resources for people to discharge, including people who experience homelessness, is that the medical beds, people get stuck in the medical beds. So they're no longer acutely sick. They don't need a physician to see them twice a day, nurses to care for them around the clock. But we're basically housing them while we're trying to solve that community problem. Now we don't have a bed to downgrade someone from the ICU into. So then you bring an individual to the emergency department who is acutely ill and needs to be in an ICU. I can't get them an ICU bed. That's our biggest fear in the hospital, is that being throttled and not having that critical care bed for someone when they're really sick, when they have a stroke, when they get hit by a car, when they fall off a building, when they're, we have a lot of laborers who are injured at work that end up in the ICU. We want to preserve those beds for people who are really, really sick. And when we end up just by default, being that custodial care that really could be provided in the community at a lower cost and a much better, safer environment, we now risk not having that critical care bed for someone when they're really ill. And I put a little box in here that is a synopsis from a few weeks ago when Kirk and Kathy and I met to talk about this presentation. On that particular morning, one of our larger hospitals, we had 22 patients boarding in the emergency room at 10 a.m. There is a lot of medical literature out there that indicates and shows that if someone spends 6 hours or more in the emergency department, their mortality and their morbidity increases. And so that's not what we want in the hospital. We want people to move into the hospital beds if they need them. So as Kirk was saying, across Western Washington, our hospitals run full almost year round. COVID certainly had a huge impact on that and made it more significant of a challenge. And additionally, many of you may know this already, but per capita across our country, Pierce County was the 3rd lowest in the number of psychiatric beds available. That has been improving. The state's been working really hard at creating more community psychiatric beds, but we still struggle with psychiatric patients who then get detained in an acute care bed, not because of a medical need, but because that medical bed becomes the de facto Washington state psychiatric bed when there isn't one in the community. So we lose some medical beds there. Again, patient rights and patient choice are drivers for our disposition planning, and then medical necessity for an acute care bed. So we work really hard not to be providing custodial care because we want that next sick person to have the access that they need. Open shelter beds, Kathy mentioned how some of our workflows just don't always sync up. In the hospital, we're looking at our watch, not our calendar. We're not Monday through Friday, we're not 8 to 4:30 or 1 p.m. to 11 p.m. We are all the time, and we just don't always sync up. We get great feedback from our community partners and want you guys to call us in the moment if you experience something that you think may have been, could have been handled better by the hospitals, we want you to call us in the moment so we can study it and learn it and understand it then, and we can help both sides understand the experience. But one example that I've seen many times when folks have called me is that during transport, the patient actually told the driver of the vehicle, take me to a different location. Do not take me to the shelter bed that the case manager got for me or the social worker got for me. So, and then sometimes we'll have a plan in play and we will have communicated with you guys, and the patients decide that's not really what I want and they might leave. More importantly, or also importantly for you guys to realize, is that there is risk when you're in the hospital longer than you need to be. There are a number of hospital acquired conditions, and certainly that's even higher now in the pandemic with COVID. But people get what's known as hospital acquired disability. You're in a bed all day long, you're having meals delivered. We cannot have you walking up and down the hallways right now with COVID, especially. Don't get to go make choices. You don't get to go select food. There's just it's a different environment. It was never meant to be long-term care. And so people get weaker, then they have to get up and go to the bathroom and they fall. And we've had people who were not in for anything orthopedic fall and have an injury. So we really do work from a medical perspective to get people out of the hospital when they're ready to go to the next level of care, because that actually improves their recovery. You can get worse in the hospital longer than you need to be because of all these other variables, and hospital-acquired infections happen as well. This is just something I wanted to add to kind of show that these issues are national. They happen in many other states. These are examples of court cases in other states where the courts actually have upheld that it is the moral duty of the community to preserve that acute care bed, that hospital bed, for emergencies and acute medical needs. And of course, hopefully, I don't think you've heard of any situations where Virginia Mason, CHI, or Multicare has actually trespassed someone out of the hospital when they wouldn't leave a bed, but that has happened in other states when the bed was really needed for somebody who was sick. And that's not what we want. That's why we want to partner with you guys on timing and sequencing, on process and on communication, but hoping that folks will understand the value of that medical bed for a medical need. And so what we, of course, are committed to doing is working with you on that process improvement, on transitions, and trying to improve warm handoffs when we discharge people to shelter. For us, a warm handoff is a contact, a phone call, a conversation, as best as we can, given some of the differences with the hours, keeping those open lines of communication and responding timely. I think I took your slide, Kurt. And then
that's fine. You're doing a great job, Kim.
Okay, sorry. I just realized that. And then continuing to support medical respite programs and even potentially growing those services with community partnerships. And so we do have 2 medical respite programs, one with Nativity House and one with Pioneer Services. So, and we are looking to grow another larger one in the community and working with some community partners right now. Multicare is to have a big, we'd love to have a 50-bed medical respite if we could, but it's taking us some time to find the right partners, the right facility, and the funding. So with that, I'm going to figure out how to stop sharing, I hope, and then that way I can see the chat too, hopefully.
Yeah, Kim, there has been a number of questions in the chat, way too many than we have time for. I don't know if one of you might have a few moments to be able to look at the chat and answer some of the questions there potentially. But I did notice one question that was kind of a global question that might be good for you to address is, are you aware of other communities that have found a way to close the gap that exists right now in Pierce County?
I think that's a great question. I think the medical respite program, the larger one that we're trying to develop, is modeled after one in Arizona called Circle of the City. And we've even brought people, I see Kim Bjorn shaking her head, we've even brought people from Virginia Mason, Franciscan, you guys are going to give me a chance to get that down, and Multicare down to Arizona to see Circle of the City. It has a clinic embedded in it. It has amazing outcomes. They have embedded case management. just like Nativity House and our Tide Flats program with Pioneer, we are offering case management services, and we've had some really, really great outcomes with both of those programs. But like Kirk said, they're small. I think we have maybe 5 to 8 beds. We've gone over capacity at Nativity House many times. They've allowed us to pay for additional beds. We have about 8 beds at Tide Flats. We need a big, robust program like that, and it needs to be connected to all the services that you guys provide, so that there's long-term support for individuals. I think that's a really good program. I know Elevate Health has been involved with us in exploring that option. And so we're really excited about that. To the comment about adding social work staffing, we're always, of course, we would never say no to getting more staff in our departments. We're both nonprofit health systems, and like you all, no margin, no mission, right? So we reinvest to keep ourselves open and to open new services and new programs like the Tide Flats, like a new program that's going to be opening at Good Samaritan for pregnant moms who have addictions. Those types of services are, obviously need to be invested in financially. And so we are held to benchmarks just like the rest of your agencies, where staffing is based on our margins. So we can't just add staff willy-nilly, like you can't either, but we do review our staffing models and ask for those kinds of staff increases when we need them. We Multicare are looking to add a little bit more support in the emergency departments. But another thing we need to do is get better at right-sizing the use of our emergency departments. And I think telehealth actually has started helping that a little bit. So this is beyond the homeless population, but people in general tend to go to the emergency department for something that could be solved in a primary care office. And so when we get better at right-sizing the use of the emergency department, then we can apply those resources better. That is true of getting better placements in the community for custodial care. And so being able to have people be maintained in an adult family home or a group setting of some kind where they get their care needs prevents that from becoming de facto use of the hospital and the ED. So it's kind of a chicken and egg thing. Our social workers would have more availability if we weren't managing a lot of those social determinants of health issues that really require long-term case management and long-term social work that you can't do in a 5-day hospital stay. I hope that makes sense.
And related to that, if I could piggyback on Kim's comment regarding the staffing, there are certain cases, of course, where we're talking about societal issues that have been present for, generations upon generation. And there are a good amount of cases where, quite honestly, it doesn't matter what our staffing was. We could put 4 or 5 social workers on that one case, and it's not going to change the fact that there is a shortage of available housing for people, or affordable housing for people who don't require any sort of follow-up medical care or anything of that sort and just need a roof over their head. Once again, I just saw the email chain yesterday about how the housing authority currently, you can't even get your name on the list. So it doesn't matter if you put 8 social workers in the hospital working on that case around the clock. If the resource does not exist in the community, I don't know, there's only so much, as Kim, pointed out, there's only so much we can figure out in a 4 to 5 day hospital stay on those issues.
And we're really meant, the social workers in the hospital, they're medical social workers, they're trained medical social workers, they're meant to work on those kinds of issues. So you're a family, you just had a 24-week preemie, that is a baby who's premature in the NICU. There's a lot of social work support for that baby and that family. There's a lot of time and effort spent there. You're a trauma patient, and there's grief and there's trauma, and there's now the family's income has been completely obliterated, and the children are distraught. There's a lot of emotional support. You're end of life in the hospital, and we're trying to help you with grieving. That's the kind of stuff that our social workers in the hospital are doing, or navigating the needs of the patients and the families because of that medical condition. And we do provide the resources and information. Our social workers have to be utility players. They have to kind of know a little bit about everything. But given the current situation in Washington State and our whole detainment process and our lack of psych beds, they have to triage who they service on those orders that Kirk was talking about. So if you have 6 people in the hospital who are in a detained bed and they're actively psychotic or they're actively suicidal, that social worker is by the bedside daily supporting the nurses and the medical doctor, because we don't have a lot of psychiatry support in these hospitals, on how to care for that patient and help them. So,
So Kim, thank you very much. I hate to cut off this good conversation, but I do know that Kimberly wanted to talk about Forensic HARPS this morning as well. So we're going to follow up with that. If you do have an opportunity to address some of the questions in the chat, or if one of you do, that would be great. I saw Kathy answering some things there. So thank you so much for coming and speaking with the group today. And
great.
we
and
will
we're happy
move
to
on.
do this more often if it's helpful, or maybe
Okay,
just
great.
do more Q&A rather than a presentation.
Sure. And we just know that we do want to be helpful in the situation as well. So if there are ways that the coalition can help with the situation, that's what we want to hear so we can move forward. All right. So Kimberly, would you like to talk about HARPS?
I would love to talk. I'm actually going to not just talk about HARPS. I have the whole Trueblood kind of review because our forensic teams kind of really work in unison together on our folks. So I'm going to start. Do I have the ability to share my screen?
Yeah, let me do that for you. Okay. All right, I've made you a co-host now.
Super. Okay, okay, give me a second as I work my magic in getting this working.
Technology.
I know, it all takes a minute, right? I want to share a second screen. Slideshow from the beginning. Okay, can you all see that screen?
Not yet.
Okay, well then let me fix that. Oh, it's because I didn't do share yet. There we go.
There you go.
All right, so, and I do have my wonderful team that some of them are shy, so they may not speak. But so again, I'm Kim Bjorn. I'm with Elevate Health, and I always start my discussions with really, because not everybody knows who Elevate Health is, and I want to make sure that everybody knows our mission, vision, and our core values. So we're here to build and drive community coalitions that transform health systems and advance whole person health for all. And our mission, our vision statement is every person in communities we serve lives a full, healthy, and vibrant life. And we do that through our core values, through community empowerment, equity, inclusion, integrity, innovation, and reverence. So I want to start really, it is a 5-minute video, but maybe that will be a nice break for everybody since we've been talking at you for a bit, because this does a nice job of kind of showing you the why Trueblood is happening. And I'm going to make this bigger.
And you need to share the audio. We're not hearing the audio.
I knew that would happen. Hold on.
Sure.
All right, hold on. I love that you all are very kind to me too. You tell I've not done this before. Hold on. And I was expecting it may not work. So how do I'm not going to spend a lot of time trying to share the audio because I don't want to deter, because you've all been talking.
Yeah, I would suggest, why don't we just go without the video? And, yeah, perfect.
Nope, it's all I was prepared for that. So I would really encourage you all though, the slides will be available to look at this video. It's about 5 minutes and it talks about 2 class members and now they're advocates, and it really helps set the tone of of Trueblood and the importance of the work it's doing. So an overview, Trueblood is a class action lawsuit, and it was named after Cassie Trueblood, who was the attorney for the plaintiff. Her initials are AB, and you can find her name, but I chose not to share it. Class members, and I'm going to be referencing them as class members throughout this presentation, because if we call them clients or call them something else, it really, I don't want to give the impression that people can just refer to these programs. They really need to be through the justice system to get referred to these programs. So the class members in this case are individuals detained in city or county jails awaiting competency services. The case challenged unconstitutional delays in competency evaluation and restoration. People were sitting in jail waiting for a very long periods of time. And if you watch that video, it will tell you the days and weeks that people are waiting for these competency evaluations. And then there's a contempt settlement agreement where the state worked with Disability Rights of Washington to develop a plan for providing services to persons involved in the criminal court system. And this agreement is not a settlement for Trueblood case itself, but an opportunity for DSH to secure itself from contempt status federal court. So there's contempt funds now that we are working with for additional services. And we just found out that they've received an extension of this funding for phase 2 and 3. And all this may not make sense to you, but this is the funds that are supporting these programs that we're going to be talking about. So definition of terms, what is competency? And that's a mental capacity for an individual to participate and be responsible for their legal proceedings or transactions. I have it written twice. Oh, competency restoration, a process of treatment, education, and support to assist those found incompetent to stand trial. And this process is intended to lead to the individuals to be adjudicated competent to proceed. So that is really the core here. We are trying to give supports to these individuals so they have actually the ability to move through the system in a supported way. Forensic, which is what you'll hear us calling a lot of our programs, is relating to courts of law or investigation and establishment of facts in a court of law. And as I said, class members are those who fall under the group affected by the class action lawsuit. So the phases of the implementation, Pierce County was one of the areas that had gone through phase 1. And these are the regional implementations. So it's competency evaluation, competency restoration, crisis triage and diversion supports, education training, and workforce development. And these are all the programs that are under these headings. And so really, I'm really focusing on today is this area, which is the outpatient competency restoration program. Also, you'll hear it be called OCRP. The residential supports is clinical appropriate, HARPS, forensic HARPS, forensic navigators. We talk a little bit about bed capacity and the crisis services. So mobile crisis response, that is really supported by Beacon, and the services are through Multicare Health System, reference it as MCR. They're really targeting and to reduce the arrests and incarcerations of the individuals experiencing a behavioral health crisis, and really diverting them into different community services that are already existing or potentially having to go through the HARPS, forensic programs. And so currently they have teams of peer specialists, care coordinators, crisis therapists, designated crisis responder who is able to assess for if they need to be detained, and a psychiatric ARMP. And I know these teams are being added to. I've been working closely a lot with Adam Parker, who actually oversees these teams. And he and I are working in coordination to make sure our first responders are educated about Trueblood, and I actually enjoy collaborating with people a lot. So I do my best to bring people into this work. And then the forensic navigators. They are state employees, and they are assigned to clients who receive court orders for competency evaluation. And they actually start with when the person is in jail. And if they are deemed competent, that ends, and that person goes through the criminal justice system. However, the class members who are deemed not competent to stand trial, and they are ordered OPCR, outpatient competency restoration, then they continue to work with them. And they do that through helping them make sure that they do the things that the whole program is set up for them to be able to stabilize, and that's attend restoration classes, adhere to their prescribed medications, and abstain from any unprescribed drugs or alcohol. And then they also work, again, in tandem with their other teams, like the PATH team and the HARPS team. They work on housing, mental health, substance use treatment, supportive employment services, and community-based case management services. And then this is OCRP. Greater Lakes is the team that has this particular work. And they are, the HCA, who kind of oversees all of these programs. They continue to support the OCRP contracted agencies and make sure that they're able to move forward with what they're supposed to be doing. They work closely with the forensic navigators, and the goal is to, again, to work with the participants, also known as class members, to achieve the ability for them to participate in their own defense. And so the components of this services are symptom management, social skills training, understanding the legal system and courtroom process, which is those classes that they're going through, and a referral to behavioral health treatment and housing and peer support. Forensic path. So this is where we're kind of getting into the realm of our homeless folks. So it's the Projects for Assistance in Transition for Homelessness. And the Forensic Path team is small but mighty. Right now, I think they have one person from Comp and one person from Greater Lakes, but they were in the process of hiring.
Let me correct that.
Yes, please do.
So Forensic Path. So I think one thing to note is both Comprehensive Life Resources and Greater Lakes Mental Health have their own traditional PATH teams, which is a funded program. The Forensic Path builds off of that assertive outreach model. Each team has about 4 individuals currently, and they work on a very targeted population of individuals. So
yeah, that's okay. No, okay, I want you to jump in because this has got many levels. I will diverge you off for a second. So when so as the ACH, which is what Elevate Health is, one of our expectations from the HCA is to actually come and talk to people like you to explain what Trueblood is, and partly to help people get engaged in services so they don't end up on this path. And so one of the things that I did was meet with each forensic team and get to know their work and how Elevate Health can support that work. And so I got to meet with 2 members, and I did not realize there were 2 others. So thank you for
Fair enough.
Craig. So again, the PATH model is intensive case management. And again, the program design is to include with enhanced certified peer counselors. They initiate participation period is about 6 months. They will hand off if need to other, like the non-forensic PATH team if needed. We'll offer help getting and keeping housing, transportation assistance, help accessing health services, and training with independent living skills. The HARPS. And I will do a shout out to the people I did earlier today. I think they are on the call, so I would love for you all to jump in and speak a little bit about what your work is. They were the first group I got to meet with, and they are through Comp and MDC. And their peers, and they have 4 teams throughout the state of Washington, but our teams, we have 2. And they focus on housing, and they're addressing barriers and finding and maintaining housing and dealing with subsidized costs. And you as the coalition know how hard that is. And the eligibility for pathways, again, for people to be part of this group, they have to be ordered to OCRP. And the plan is, you know, to have the data analyst referral list to make sure people are on it that should be on it. And then we're meeting crisis triage stabilization criteria for access. When I met with the HARPS team, I wanted to make sure that they knew the resources in our community, and I wanted to connect them to this group because they're working really hard. And I'm lucky because I've been able to develop a relationship, and a couple have reached out to me in trying to problem solve in some cases. And I would like for them to speak up, but I know that they use motels often. And I was looking in the chat when we were talking before with the hospital systems about are people able to be sent to motels? And yes, that is probably the main area that people are living as they're trying to secure more stabilized long-term housing.
And I would chime in that is actually just a starting point as teams work towards, it's not meant to be the long-term solution.
Right, right.
So we all know the barriers that we're putting with.
Yes. So the additional programs, and I did not want to get into, you know, we have all been talking at you for a very long time. So I wanted to at least tell you about the other programs, and there's links that do a nice job of doing concise information about what that program does and what the makeup of those programs are. And for me, this was really just to talk about, you know, you have the class member and you have all these different systems that are touching this person. And not every, as we know, we're not all in sync, and we're not, and it takes time to these major systems to be able to know what the other system is doing. And that's partly what the ACH's role is, to see where the links need to happen. And it takes a while, and these teams just kind of started formulating this past summer. In the midst of COVID, they are trying to seek people out, engage with them, started virtually, realized virtual wasn't working, so they started going back out in person and trying to connect with folks. It's about relationships. It's about willing to go into uncomfortable places and show that I'm here to help support you through this road of uncertainty when you're dealing with a behavioral health issue. So there's many meetings that happen to help with that organization. There's the quarterly state Trueblood update that anybody can sign up for if they're interested in it. There's a Pierce County operations meeting. There's the crisis collaborative. There's the elemental meeting where everybody comes together and talks about clients and barriers and successes that they're seeing. There's a criminal justice steering committee. And now as Elevate Health, we have separate one-off meetings trying to help coordinate things. So just to show that there is a lot of involvement and coordination happening to have some success around this. And then if you want more information, I gave even more connections to there's just a lot of information out there. So I just want to make sure people don't just take what I say, that they actually do their own investigation if they're interested. Again, and the other piece that I put on here was Elevate Health referral link, because I know you all are looking for a place where we can refer our folks that are struggling, and Elevate Health can be one of those places. We have pathways where we actually help people with social determinants in health and help get them connected. So please look at that if you are struggling with a particular individual that you're serving. I have my contact information on here, and I also added our wonderful contacts with our HCA and state partners. Craig is on there. So if you need that information, it is there. And that's all I have to say. And I'm open for questions.
Thank you, Kimberly. So the first thing that I think I will ask, I saw some people asking for the presentation. If you can drop that in the chat.
Oh, absolutely.
That'd be a great way to get it to folks.
All right.
And if you don't mind putting your contact information in the chat as well, just so people can copy it. We do have time for a couple of questions before we move on to the next item. There's been a number of questions in the chat, so Kimberly, maybe you can kind of look back at some of those.
Okay.
But I'll open it up for a couple of questions if people want to raise their hands and let me know you want to talk, or just jump in.
I'm going to go back and start looking at this too.
Perfect.
I feel like I should say something about the medical respite. I feel I'm very humbled that I got to work with almost everybody who has presented today from the hospitals. And I feel it's an important resource that we need to bring to our community. So I will say Elevate Health is starting to look at a broader version of our medical respite. And so, but we're in the beginning stages, and as that grows, I will be more than willing to come and talk to this group about that. But, you know, we don't want to present something that's not really solid yet. So give us a few months, but we see that as a huge need for our community.
Great, thank you, Kim.
Mm-hmm.
And since I don't see any burning questions, I'll let you answer things in the chat, and we'll move in on our agenda. But I want to thank you and all of the team that joined us today, and give a shout out to my coworkers from MDC. And with that point of privilege, move on to government updates. So thank you very much, Kimberly.
Yes, my pleasure.
So next item in our agenda, let's move to some quick government updates. Valerie, are you available to talk about the county?
Yeah, of course.
Perfect.
So thanks everybody for having me. We finally got our FAQs from the Department of Treasury, so that was great news. We'd been waiting weeks and weeks and weeks for that. So we are working very closely with the state to get the rental assistance program just finalized. The landlord portal will open today. So landlords will be able to go in and pre-register for their stuff today. And then the tenant portal will be able to, is opening March 8th. So on March 8th, tenants will be able to go in and complete the rest of their information. It is up to 12 months of rental assistance. It is also utilities, and a big change that they just made was it includes internet now. So good news all the way around. And so that is huge. Yep. We are working with the state because we will allow those informal family and friend agreements. There are a few extra steps they have to do because of ERAP was super easy, right? You filled out a form. This one's a little harder. We're going to have some backup documentation for that informal agreement. We are also going to allow hotel and motel for long-term stayers. So you can't put someone in the hotel today and then call me and ask us pay. That's not how it works. They have to show that they've been there and been paying for quite some time. So all of that is huge news. We also just got our state allocation. So we received just over 32 million from the state. And so we have 20 million from the feds, 32 million from the state, plus 4.8 from the state, all to be spent between, some of it has to be spent by June, the rest has to be spent by December. So just working through all the little nuances, all the little requirements, and we are updating the FAQs on the website. So you'll be able to go there and just get very clearly outlined expectations and what's going to happen next. So busy weekend, but we'll have it all done by Monday. So if you have any questions, I'm here to help.
Thank you, Valerie. Any quick questions for Valerie before we move on?
I have one. I didn't understand how people get connected with this program.
Yeah, so there's a couple options. One, if they have internet, they'll be able to go to our website. So if you just Google Pierce County Housing Help, and I'll put the link in the website in the chat here in a second, you will be able to go through the portal on March 8th and apply. For someone who does not have internet or is just not really internet savvy, they will actually be able to call 211. So 211 is not going to give status updates, but they will help folks without internet fill out the application. What's really cool about this portal is once you filled out the application, you'll actually be able to log back in and check for status updates on your own, which is huge because you couldn't do that last year. And you'll be able to go back in and say, April 2nd, you know you can't pay your rent in April. I need help with April. And you'll just be able to do it through the portal. And that will automatically trigger your provider to issue another check. So streamlined process, trying to just make it as easy on clients and households as possible. So yeah, I'll put the website in the chat box.
Thank you, Valerie.
You're welcome.
So let's shift. Tegan, you said you had some additional City of Tacoma updates.
I do, thanks. So the first one I want to share is, so there was a homeless update this Tuesday during study session. I will put a link to the video in the chat so that everyone can see it. Next Friday, our director, Linda Stewart, will be coming to answer questions and talk about it more. So get your questions ready for her. That'll be a great place to discuss it with her. The other big update I wanted to share was the RFP for the youth and young adult shelter has been extended to March 23rd. So we're extending the deadline to get applications for that as well. So we just wanted to let everyone know about that as well. And those are my big updates.
Thank you, Tegan. So I see you, Rihanna, from the Tacoma Pierce County Health Department. Do you have any updates for us this week, Rihanna?
I have just a few small ones. Hi, everyone. My name is Rihanna Betancourt, and I am at the Tacoma Pierce County Health Department. My activated role is to, as a community liaison, help ensure equitable access to vaccine education. And so, full disclosure, I don't work with directly with investigations and outbreaks. And so just putting that out there, when I do get concerns, I send them up the chain. We operate in a ICS structure, and so that's what I do. So I'm gonna put some links in the chat about how to sign up for notifications about community vaccine clinics. And then also some other stuff from our webpage. And so the vaccine education can come in the form of presentations, distributable flyers. I can email them to you to post at your agencies physically. Yeah, so I'm gonna drop those links in the chat, and if anybody, I have a question. Can we swap me with Ivan on the agenda? Ivan works more closely with investigations and outbreaks, and I often get questions about that stuff, and he's more hip to that than I am.
We certainly could. The trick is that Ivan has not been attending these meetings very often, so it would
all right.
probably be in name only if we did that.
Okay, okay, understood. All right,
Yeah.
I'll put my contact information in the chat.
Great, thank you, Rihanna. And you'll probably sense we've had a very information-packed meeting today, so we are kind of rushing through the remainder of the agenda, but I don't want to cut things off. So next up, we have Colin DeForest. Do you have updates for Safe Parking Network?
Oh, yes, I can give some quick updates. Basically, the East Pier site, South Hill Baptist site is full. We've been shuffling people through there quite quickly, but it is full right now. Our Tacoma site has 2 openings. We just moved or in the process of moving in a pregnant mom living in her vehicle. So if anybody knows of any other resources for a pregnant female who's living in her vehicle, please let me know. Reach out to me. So that's going good at both. So both of those sites, we have two dates, and I'm going to touch some wood. We have not had one call for service from police or any issues at the site. Things have gone great. So that is awesome. Other updates, the slow rolling ball of the TCC project is still rolling, albeit slowly. I have a meeting, so I did a PowerPoint presentation for their leadership last week. This week, so they had some questions that came out of that this week. So this coming week, I'm meeting with the president of TCC, which is going to be hopefully one of the last meetings, but I'm guessing not. So very positive, lots of interest. I'm definitely optimistic that this is going to happen. I just hope it happens during the school year. So we got that going on still. Salvation Army in Puyallup. So Kaina Kelly and her husband went through the application process. They were with the Safe Parking Network. So we have okayed them and cleared them to move forward. So we are moving forward with Salvation Army as a site. There'll be more on that, but we're going through the process. They are looking to serve 3 individuals, 3 senior citizen women. And unfortunately, that's a thing in Puyallup, and they have senior women already selected, I believe. So, I mean, it's an example of, it's just really unfortunate that that's actually a thing in our cities, that there's senior citizen women living in vehicles. But I applaud them for reaching out. It's also exciting because they're doing it in a way where, with it being under the umbrella of the Safe Parking Network, they don't have to go through their kind of chain of command, which a lot of us know about with Salvation Army, which really goes national. So I'm hopeful to have a similar conversation with the Tacoma site. Don't know if anything will come of that. And then lastly, I would say Cindy has just not let the ball drop with her church, with Tacoma Unitarian Universalists. So we have kind of really been talking, Janet, myself, others from the Safe Parking Group, with Cindy for, gosh, a couple months. And they are, and I don't want to get ahead of myself, but they're going through the application process. So they've had some meetings, and it looks like they're going to be moving forward. They're very excited. We're very excited. I think that'll be a great to have another site in Tacoma. And I think off of 56, that's a really good area also. So outside of that, I really don't have much more. We've had a couple issues that have come up. There's been a lot of calls this week. It's really ramping up. I will be completely honest. One of the things that we were hoping to do with any pilot program is just learn, is there a need for this? And I will say I am extremely surprised that the families just have not. We've had like 2 families that have come through the program. So there just are not a lot of families out there, which honestly is good. Anecdotally, what I'm hearing is a lot of those families, because of the cold weather, are doubled up on couches. So we'll see if that changes as the weather starts to turn. But we most definitely have a lot of individuals and a lot of couples and a lot of seniors. That's a really big thing. We had one of our individuals at our Tacoma site who had to go into the hospital. Luckily, we were able to help her, which is one of the great things about this site, because, and I might have mentioned this last week, but just from sitting for too long, her circulation is having challenges in her legs. So she had to go into the hospital and get that looked at. But once again, we were able to help her because she was at the safe parking site. So great stuff there. We had another one that kind of came through the coalition. That was a van that was parked. And this is an example of what, unfortunately, there's gaps within the safe parking network, and whether it's RVs or vehicles that are not running. So there was a van that was not running. We had some great neighbors that were willing to tow the van to one of our safe parking sites, but unfortunately, that's a can of worms that we're not gonna get into at this time. So that was unfortunate, and unfortunately, that van, I just got word this morning, ended up getting towed by the city, I'm guessing. So kind of an example of why we do need the safe parking sites, but also it doesn't work for everyone. So that is about all I have.
Thank you, Colin, and thanks for all the work you and the Safe Parking Network are doing. Great progress. So I think at this point in the agenda, we will shuffle some things around and shift over to Garrett and then Maureen for some quick updates about coalition happenings in the last week and then advocacy.
Did you want to go first, Maureen? So we all voted last week to take on a leadership role within the county to end homelessness, and also to take a leadership role in creating enough shelter in the community, like creating, meaning inspiring others to spend money to create a shelter so that our hospitals, as they're describing their challenges with shelter today, go away. So that by November 1st of this year, there is a place where everybody belongs, whether it's Colin's amazing safe parking network, not just Colin, but Jan and lots of others. But again, can't emphasize enough how amazing it is that today we have safe parking, and we didn't last year, and we've been trying for a long time. And that persistence really paid off, and it's, yeah, stunning. So we voted on those two things, well, really three, right? A third thing was to figure out what our coalition structure needs to be. And to do both of those tasks, we needed to have both the county council and the city council on board, right? They're not just partners, they're the major players. And in our discussions with the county council, it turned out that the county council was very interested in seeing this work happen, and they didn't want to be one of our partners. They wanted to be leading the work. And so we've been in discussions with Derek Young and his staff and others on the county council about the county council allocating substantial additional funding for Pierce County to hire staff and to take a lead on this with a target of creating a plan by the beginning of July, right? So that's pretty aggressive for a plan, period, pretty aggressive for a government agency. So to us, I know Maureen says, we're going to call this a win. And it takes a little bit of the control out of our hands, which may not be a bad thing, but probably us stepping into this space helped to hasten that conversation about the county taking this work on. And so I'm confident it's going to be successful. Our fingers are going to be involved in it, and we just need to see it play out. So it's kind of in the political staff discussing, county council discussing, us discussing with city council. So lots of things are up in the air. So my update is, wow, things are different than they were last week. But the destination we want to get at looks to be on track. Just our pathway to get there appears to be a little bit different than when we left the meeting last week. And I don't want to take up too much time. We're definitely talking about this at our steering committee meeting, although perhaps a better run discussion than I ran last Wednesday. It's just a lot of things up in the air. And so, again, thoughts are always welcome to me and Kevin and Maureen. Attend the steering committee meeting on next Wednesday at 3. The link's on our website. And I don't think I have time for questions, Rob, but I can do some in chat, or you can just reach out to me directly.
Okay, Garrett, and now hand it over to Maureen.
So to try and make the steering committee meetings work a little closer to agendas, I'm inviting anybody who wants to know the nitty gritty of anything that's on the agenda to join me at 2:30 on Wednesday before the steering committee, so that if you want the painful weeds of detail, we can do it then. And hopefully the steering committee meeting itself can be more interactive than the last one, because we do have an enormous amount of information that we want to share with anybody who wants to be part of it. So, all right. So a year ago, I was encouraging all of you to please make an emergency plan for yourself, your family, and your organization, because of what I thought was going to happen with the virus. Sometimes I turn out to be right, and it doesn't make me very happy. But it turned out that that was good guidance. So rather than going through a list of bills, what I want to do is highlight some pieces of our system, our overall system, that I think are important to keep an eye on, and some that I think are important not to panic over. So we have a real homelessness prevention system now through the rental assistance that we've had for the last year and that we have coming that we did not have a year ago. What we also have is an active eviction defense kind of program or working group or whatever. The coalition doesn't run that, but participates in that. If you heard the news yesterday or today that a federal judge has blocked the CDC moratorium on evictions, the eviction moratorium saying it is not constitutional, do not panic. We are governed by a Washington state eviction moratorium, all right? Our champions at the federal level have already taken up that federal CDC issue, and we may need it going forward. We don't know if the governor will extend the moratorium beyond March 31st or not, but do not panic over that news in Washington state. We are, there will be efforts to get the governor to extend our eviction moratorium. And so just watch for those. We will follow the Washington Low Income Housing Alliance on those efforts. The King County Superior Court stated in the last day or so that the tenant protections that have been added in the city of Seattle are legal. This is a very good precedent. We are fortunate in Pierce County. We're part of that eviction resolution program. We've got Tacoma Pro Bono. We've got Northwest Justice. We've got Chiquata Elder at the city. And we've got all that wonderful money that Valerie's going to get out. So the thing is to make sure that all eligible renters apply for the money. And that may include yourselves, and it may include people with whom you work. All right. You have every right to apply for anything for which you are eligible. All right. We need all staff as healthy as possible. And that means that you all stay housed. And I know some of you are working at some below housing wages. So please do not be embarrassed. It's all private information. Nobody's going to know. So if you are eligible, please use that portal. Encourage your friends to do the same. We have got to figure out tenant organizing in a better way so that tenants have tenant voices at tables rather than well-intentioned homeowners representing tenants. So that's a gap in this overall system. With respect to tenant protections changes in the laws, we don't know what the state legislature is going to do until they do it. So we can all project all kinds of possibilities, but nothing's dead until its session's over, really. With the city of Tacoma, and somebody's going to put this deck in for me, slide deck in, Garrett, I think. So the Chiquata Elder brought forward the proposed changes, a summary of the proposed rental housing code changes at the council study session. And you've gotten this already on the, you've gotten the links already from me. And the study session link that Tegan put in, you just back it up and you'll pick up the presentation on the rental housing code changes. So these are going to affect what we loosely call shared housing, among other things. So whether it's people renting rooms, whether it's people going together and sharing, one lease, whatever it looks like, this is part of what these changes are looking at. This is City of Tacoma. The housing sits in the City of Tacoma, okay? And Chiquata has worked closely with Mark Merrill and Shared Housing. She's going to be coming to the coalition meeting, I think next Friday, to talk about this. So this is what's really important. And Valerie, I'm going to reach out to you separately to see if you can help us make sure we get everybody invited that we want here. If you are operating clean and sober housing, any kind of housing in which people are sharing rooms, anything you call transitional housing, it doesn't matter whether you are taking rent for the unit or taking rent to be in the program, whatever that structure looks like, and you do that in the City of Tacoma, I encourage you to be at next week's meeting so that you have an opportunity to listen to Chiquata and to talk with her, because that's what she's doing. She's getting information. And her slide is just 2 pages. I mean, it's a really easy piece. Now, there's some good news, really good news. So the city council, and this, I think there's a slide to go in for this, 1590, the slide deck. The city council did listen to the presentation on using House Bill 1590, which is the 1/10 of 1% for affordable housing development. And it appears that they are ready to move forward. And we're hoping there will be an ordinance on March 9th. First reading, second reading, March 16th is the most recent set of dates that I've seen. And this does not diminish the work that St. Leo's Social Justice Committee under Carolyn Reed's Revenue for Housing leadership is doing with the county as a whole. The law allows an individual jurisdiction to move forward on its own, and Pierce County, City of Tacoma Council appears it is going to do that. And that will put money into the city's housing trust fund, specifically around the development of affordable housing and the services that accompany it, including permanent supportive housing. There may be some state changes that allow acquisition, and if so, everything will be amended to reflect that. And now this is a really fun one. Every once in a while, somebody says, hey, can you help us do this? So we've been contacted by some private folks, private investors, who would like to invest their money in the development of affordable housing that helps to end homelessness. They believe they'll have about $500,000, which is, in the scheme of affordable housing development, does not seem like very much money. But for those of you who have small projects, who might want to purchase the house that you are currently renting for your program, or might need a gap just to get started or to secure property, that sort of thing, I want to hear from you in the chat now, or just email me. You know how to find me. How you could use this kind of money. This would be loan money. It would be a revolving loan fund. Think of it as the mutual self-help, food not bombs, collective community volunteer level of affordable housing development. So how do we make this as fair as possible, as easy as possible? What is reasonable risk management for the organization? What's reasonable risk management for the project? And the people who are interested in doing this are open to anything that we bring forward. So in my world, this is like bright shining lights that we would have this kind of an invitation. Would the fund get bigger? I have no idea. We never know. But it's something that is on the table right now. So please reach out. Last thing on my list, COVID and year 2. So looking ahead, shelters and COVID in year 2. I think we have to assume that the guidance from CDC does not change until late summer at the earliest, certainly not until we have a majority of people who are in shelters, who are unsheltered, and all of the staff vaccinated. And I think that if your organization has not looked at the federal payroll protection program, I encourage you to do that. There is more availability, especially for the smaller organizations. We have been working with Pierce County Human Services, the Health Department, Emergency Management, the city NCS on outbreaks in shelters, outbreaks in the pilot camp. You heard Irene and Arrow talk about that. Increasing the access to the temporary care center, making it more friendly, or providing an alternative site for people who are experiencing homelessness. And with respect to the non-congregate shelters, and I know many of you are hoping that the city and county would use FEMA for hotel rooms for people who were not COVID positive, but by the fact of their homelessness and needed a place, and because we don't have enough shelter beds that meet everybody's needs. And we've met at length with the City of Tacoma, with the mayor at her request, with Linda Stewart, the director of NCS, with Linda Stewart at her request, with a couple of council members at their request. Part of what it comes down to in the city is that they're using this particular pot of FEMA. They're using it, they used it for the warming centers, they're using it at 60th and McKinley. They it's a budget process issue that I'm not going to delve into. Come at 2:30 on Wednesday if you want to know the nitty gritty of that. But, and I just haven't had a chance to check with the county and see if it's the same issue with them. So do not think that the local governments are not looking at, or in the case of the city of Tacoma using this resource, they're just not using it the way we want them to use it, which is a different conversation. So anyway, thank you. You know how to find me. Be well.
Thank you for all of that, Maureen and Garrett. So we only have a few minutes left in our meeting. Kevin, do you have any quick updates for commitments that you wanted to share before we?
I do. Thanks, Rob. I was. Colin already shared the safe parking updates, and it's exciting to see the progress being made there and the learnings that's going forward. Been meeting, and I see Mike Yoder below me on my screen, but Mike Yoder and Tim Thomas from Oasis, and Alan Brown and Nick Leiter from CCS and I have been talking about building a model that will help churches rather than stand up shelters, but to welcome in a family or an individual for an extended period of time while that family or individual is being supported through case management or rapid rehousing or different options to kind of take some of those folks out of the system who will be easier to rehouse, and also make use of church partners wanting to do what they can but not be overwhelmed. There are 2 churches doing that currently now, and I've talked with one, and they've had a positive experience, so that's underway. I'm going to start again with a follow-up, just following on the information from Jeffrey about the proposed sweep at 38th and G, with reaching out to the various mayors and police chiefs, asking them to support the no sweep policy during this time. I did that following the summit, but haven't heard back. And then there was an excellent meeting of providers yesterday hosted by Valerie Knight. Thank you, Valerie, for outreach workers, looking at how to best work together with the health, health department was part of the conversation, but how to get all the public and private and personal entities together to do vaccine outreach at encampments, and looking at different models, how we can take down the barriers for people who don't trust the medical system, whether the Johnson & Johnson shot might be a better option, given that it's a one-time shot rather than having to track people for a second time. But it was a good first meeting. And again, really shout out to Valerie for pulling people together, for the folks who attended. Yeah, so those are the key things at this point, since we're just about out of time.
So anybody have any items to just give updates for the good of the order before we let everybody go?
Yes, I do. Purple Bag Program. All right, I had a nice conversation with Brandon with Environmental Services. Purple Bag Program will continue with Environmental Services, meaning that it only will be used at camps where any runoff from an encampment or garbage from an encampment impacts a river, stream, or some other water mitigation site, but only under those circumstances. So other garbage help, which is really kind of interesting out there right now, will just happen as it happens currently.
Okay, and I dropped in the chat, Jeffrey, that Brandon is going to be on the agenda next week to talk again about the Purple Bag project and the current status. Colin, I see your hand up.
Just to follow up, and I was kind of in and out at the beginning of this meeting, is there any more information on that potential sweep of the 38th camp, and what is that?
Jeffrey, do you want to kind of...
Yeah, I've been in contact with Councilwoman Ushko. Hang on just a second. Sorry, I have a puppy who's noisy. Killed it. Anyway, the last I heard in talking to some of the residents is they have been told by the CLO, Steve Bucks, that indeed something has happened. Ushka has also informed me that likely something was going to happen. The fact is they've gone from 10 people to 20 people. Some of the people have come in, have broken windows in the building, and have used the space inside the buildings rather than respecting the buildings. And this is really, we're at a situation where both the city, the police, and myself are concerned for the safety of the campers on that site. So where they're going to go, I don't know. I'm hoping to tie in with one or two of them today and find out if they have found another encampment to go to or whether they're going to form another encampment.
Thank you, Jeffrey.
And I would just say too, Jeffrey, I've reached out to the city to ask what their plans are around providing either helping people find another place to go or storage of their items in this interim period. I just sent that email, so I'll keep you posted if I hear anything.
Thanks, Kevin. Jennifer, I see your hand up.
Hi, Jennifer Ammons, Northwest Justice Project. And I just wanted to follow up on there was an article in the TNT last week saying that a number of y'all have had problems with people who have behavioral health issues, mental health disabilities, being turned away from the TCC. And I just wanted to point out, it was the first time that I had heard there was a particular population like that might be a protected class that is getting turned away there. So follow up with me if you have those. I'd love to get the numbers just to see if we can do something about that. Thanks.
Thank you, Jennifer. And Julian, I see your hand up. Julian?
Oh.
There you go. I can hear you now.
Thank you. Just another reminder of our Pierce County ACAC meeting coming up on March 9th.
Sorry, Julian, you're cutting in and out on your audio.
I don't know if you can hear my voice, but I put it in the chat box. So
okay, perfect. All right, so I said it in chat, but I'll say it here too. We have reached the time, or actually overtime for our meeting, so appreciate everybody being here. Sure hope that you have a safe weekend, and if you want to stay on the call, we'll spend the next 30 minutes or so with a smaller group planning next week's meeting after we take about a 5-minute break. So thank you for being here, everybody. Have a good weekend.